Welcome to the High Dimensional Podcast. In this episode, Phil and I speak with Mara Alexeev, Director of Clinical Informatics at Layer Health. Mara is a pediatrician by training and has spent time at Kaiser, Memorial Sloan Kettering, and Boston Children's. We discuss her career, what clinical informatics was like 10 to 15 years ago when she was just getting started, and where it's heading in the future. A really exciting conversation you'll hear now. Mara, thanks so much for being here.
It's a pleasure.
Super excited for our discussion. We're going to get into a bunch of topics, but I think first, I know you decently well over the last couple of years. You're just meeting Phil for the first time, so I know Phil's interested to get to know you a little bit better, and I think the audience would be interested as well. So maybe just go through your background a little bit before we dive in.
So I am a pediatrician by training. So I grew up in Iowa, went to college in Iowa, went to medical school in Iowa, spent 26 years there, and then this little farm girl went out to Oakland, California for residency in pediatrics. I stayed there for a bit. I had the real wonderful pleasure of doing residency, my pediatrics residency at Kaiser Permanente, which is a very, very interesting like a wonderful hospital that I was at with wonderful people, but also a very interesting approach to both data and to healthcare delivery. And also a little bit of foreshadowing of understanding the non-data parts of data living in California, because there's some really nuanced and special ways that healthcare is affected when it's delivered in California. And so after pediatrics residency, I did another year at Berkeley and got my master's in public health there. I then practiced in the great state of Hawaii as a private practice pediatrician for a while, lovely Maui. And then I worked in New York City in the Department of Health and Mental Hygiene for a bit. And then in a very bizarre twist, I went to, I decided I wanted to do something different than practice directly with patient care as my primary focus. And we can talk about that at a later time. But I found out about clinical informatics, and that is when I decided, I'm going to go do a fellowship in clinical informatics. And so I had stepped away from work for a little bit with the birth of my first son, and then got myself together to applying for fellowship. And then, as you guys may or may not know, start times in residency and fellowship are incredibly regimented. There's no leeway. You start in July, you end at the last day of June. This is just how the sequence goes. So I submit my application, and it's I'm going to be doing fellowship in a year. What else am I going to do for the next year? So this is a very non-standard thing, so don't think that other physicians would have done this. But after having practiced as an attending physician, so that means practicing independently and seeing my own patients, I actually went back and was a chief resident at Memorial Sloan Kettering Cancer Center, which is not normal. Usually people go right from residency to chief residency. So it's very unusual to have an attending physician become a chief resident. But it turned out to be one of the most amazing experiences in my life. It just so happened I lived a few blocks south of MSK, and I needed a year-long job, and they needed a year-long chief resident. So I was there for a year from 2019 to 2020. And then I went and did fellowship in clinical informatics at Boston Children's Hospital. And after that, I worked in a startup, and I recently joined another startup in April. So I'm now the director of clinical informatics at Layer Health. So that's kind of my professional journey. And I would say to summarize who I am now is that I'm a clinical data detective. So anything you want to know about healthcare data, I might know it, or if I don't know it and I haven't heard about it before, I definitely want to know it. So that's like, that would be the like one line summary of what I'm up to. So yeah, that's Mara.
I love that. Um, I would love to you mentioned like I would love to like unpack the like just the discovering of clinical informatics. Kind of it sounds like that kind of happened in New York or but
No, so this happened. I can, like, one of my friends who's a physician, she's an oncologist now, she can probably tell you the moment that I articulated like clinical informatics to her without using those words. So in your fourth year of medical school at University of Iowa, you have to do one of two things. You have to either do 4 weeks in the emergency room, or you have to do 4 weeks in an intensive care unit. I am not, if you knew me personally, I am not an emergency room person. It is not where I love to be. Like, if you break your arm, great. I love it. I'll fix it for you. But like, there's just many things that comes into the emergency room that I'll pass on. Like, I will find you a great person to take care of that, but that's not Mara.
is it the is it like the chaos kind of it or
No,
what is
I
it?
like the chaos. I like chaos. That's totally fine. It's working unusual hours. Like, I just don't, like, some people function really well at night. Like, I don't. Like, I remember one time in residency, like getting woken up at 2 a.m. and I was like, to go to take care of a kid in the ED who I needed to admit to the ICU. And I thought, like, this is 1,000 times harder for me at 2 a.m. than it is at 2 p.m. I'd admit 100 kids in the afternoon if I could just sleep at 2 a.m. So,
Yeah.
so I think there's like a deep, it's interesting when you meet people who are in medical school and they're like thinking about what residency they're going to go, which specialty. It's almost like you're kind of like figuring out which character build you are from like video games of like, are you the stealth archer or are you the berserker? And you have to figure out which type of like medical specialty character build you are. And there are subtypes and things, but yes, I'm not the ED.
You're not the ED.
I'm
Yeah.
not the ED. So I ended up in the ICU, in the adult ICU, even though I knew I was going into pediatrics.
Yeah.
Complicated reasons there, but it is what it is. And so we are rounding, and what we do, if you guys aren't familiar with like how the hospital works from the physician side of things, it's different for nurses, but for physicians, we get there very early, typically in the morning when you're working the day shift. We look at the computer, we like scour through our patient's chart, the nurses and the lab, all this information, and we like scour through and look in 10,000 little different places, and then we write on our little note cards what our sheets of paper, whatever our rounding technique is. Then several hours later, after maybe we spent like 30 seconds examining our patient, we go and we stand up and we round and we talk about what we know about our patient from this information that we have somebody put into the computer. We extracted, put it on a piece of paper, and then now several hours later are reading these values to somebody, the attending physician. And I just like thought, that's silly. Like,
Yeah.
this is not the way we should digest this information. So I remember telling my friend Meredith this of like, this seems like we could be doing something different and better. The good thing is it still actually works okay. Like, it works pretty well. So that it's got that going for it. Then in residency, I was very interested in eliminating like busy work. That's important, but it's busy work. And this is also a part of clinical informatics. So like this example I gave in the ICU is like, how do we manage data? What's the quality of data, the latency of the data, the accuracy, all that kind of stuff. Then there's this other thing of there's just a lot of work that goes into the busyness of a hospital. Like, if you've ever been in a hospital yourself or with a loved one, there's just like, oh, the doctor's got to put an order in for me to eat. Like, I've been sitting here for 2 hours after my surgery. Why can't I eat? The surgeon said I could eat. And the nurse is like, sorry, there's no order in the
There's
computer
no
for
order
you to
for the
eat.
food.
Yeah,
Yeah.
and it's like, it's crazy making because behind the scenes, there's just a million things that are going on. Because it's very important in many situations that if a patient is not supposed to eat, they're not supposed to eat, right? And so there's just these systems that are built up to stop like the worst possible thing from happening. And sometimes the tension there is like for other non-critical situations, it gets difficult.
Less efficient, yeah.
Yes, less efficient. And so one of the things that I got big into is, so this is a little bit sad, so is that a lot of pediatric inpatient medicine, so taking care of children inside the hospital, has to do with oncology, so cancer. Because children are actually very, very healthy, typically, we don't actually have, like kids don't get hospitalized for a lot of stuff. However, in the rare situations they do have cancer, these kids get hospitalized a lot because of the chemotherapy that we do. They have to come in because it's like you have 5 days of chemotherapy for 10 hours a day. And so we can't really, like, it's too much for the families to be going back and forth. And sometimes the chemo is so intense that you just can't do that as an outpatient. And so these are patients that you deal with a lot as a pediatrician during your training. And they have like a lot of complicated needs, but not really, right? Like a checklist will get you 95% of the way to everything that they need for most cases. And we just didn't have those checklists. So I got really into during residency to take these things that don't involve high-level physician thinking to just kind of like, we don't need to think about this. If you think a patient has leukemia and you're admitting them from the emergency room, you call the oncologist, you say, I think this kid has leukemia. And the oncologist said, we'll talk with you and make sure, like, yes, we're all in agreement. We need to do a workup for leukemia here. But then once you decide you should just be able to trigger all the labs, all the procedures, all the dietary restrictions that you don't need to go in. Is it like, do I need to get a direct bilirubin or an indirect bilirubin? Like, don't worry about it. Just click and go. So
Yep.
that was another big thing of informatics that I got interested. Still do.
And so, and by that, do you mean like you're creating order sets there, where
Order
it's like
sets, yes,
when this
exactly.
happens, do this, and then all these things are ordered.
Yes.
Kind of.
So like make a decision, help the physician make a decision where the decision is important. The decision is important when you have decided that you are going to work this patient out for leukemia. That's the decision point. Once you've decided that, there's many other decisions you no longer need to make. These are
Yep.
a lot.
Were you working directly with like the build team for the EHR to build those things, or were you part of kind of like a council, or like how did that
No,
decision making
just
happen?
rogue.
Just
So
do it.
there's different levels. And so this, so Kaiser is on something called Health Connect, which is an Epic. Like they were a very early customer of Epic, but they just kind of like some institutions brand it slightly different. So we would call it Health Connect. So if I accidentally say Health Connect, that's what I mean, but it was an Epic. So I was in residency 2012 to 2015. So that kind of tells you a little bit about the maturity of things. Kaiser's was more mature than the typical institution at that point in time. And so you're exactly right. There's like different levels of organizational control over things. And that's what we typically call governance of like how things work inside the hospital. And so at that time, there was still quite a bit of flexibility at like the individual level. So I could like make an order set and then share it with other people. This might be disabled at this point in time.
Yeah.
Also, places have gotten much better at making it much more rapid that you could get an order set of what you
Yeah.
needed done. So that has probably changed a lot over time. But so my maiden name was Detterman. And after I got married, my last name changed to Alexeev. And I was put in touch with some residents who were at my residency or last year or something like this, because they were interested in going into clinical informatics. And they were talking to me and they're like, wait, are you Mara Detterman? And I'm like, yeah, that was me. And they're like, we still use your templates. And Kaiser, because
That's a good order set.
Yeah.
That's
And
how,
then,
that's how you
well,
know you made a good order set.
it's not even order sets, it's note templates that I got
Oh.
tired of like trying to search for people's like, where are you keeping this information? And it's like, everybody doesn't want to come with this like a note template. So I came up with note templates like, here's a rheumatology note template. This is an urgent, like, I love this kind of stuff. Not everybody loves this kind of stuff, but like I like fantasize about like when somebody reads, it's like physician fantasies, right? Like when somebody reads my note, they're like, yes, I understand what this patient was about and what Dr. Alexeev was thinking about. So this has been like, you can start to see the arc of Mara's like, I love the information, I love organizing it, and I love helping other people do what they want to do. And then this is such a nerdy thing. I read a really cool paper called Tidy Data. So back in like 2018 or something,
Hadley Wickham's
Hadley
like our
Wickham,
paper.
Yeah.
who also got his PhD from Iowa State, Aaron. So we're just
Wow, the Iowa connections.
The Iowa connection is strong.
The listeners probably don't know that I'm from Iowa too. And yeah, we got tons of Iowa connections going on in this
Connection. I
episode.
love it. And so I read that, and it really, to like get a little bit of context, medical data is rough, and we can talk more about how it's rough and in the ways that it's rough. But he talks a lot in that paper about like making each row a single observation. Don't cram too much in. And go and read the paper. I think it is truly called Tidy Data or something like this. And that was really exciting for me. And that actually spurred that I actually learned while I was off that year with my firstborn. I learned how to program. And so that was another really like
Did you learn in R or what did you?
I learned first in R. Yes.
Nice. Yeah.
And I literally I think it's over on my bookshelf still. I think it's still over there. I just like got R for data science.
Yeah.
And I just like went page by page by page through it. And I learned so much, and like, it's unbelievable. Like, we have all these amazing tools now, but you can actually learn a ton by getting a book and sitting down and just typing in the exercise or doing the exercises that are in the book. So thank you, Hadley. It was great. And then, so that also it really brought a lot of things together of like, there's so much data out there, but we aren't always like, we can't get at it. We don't know what to do with it. We spend so much time trying to organize it. There's just a lot of complications.
So let me like dig into this a little bit. So like when you the like your early like informatics work was a lot around like the EHR and how to like optimize things, like getting information into the system so it's like more user friendly coming out of the system, right? Or it's just like increasing efficiency. Was when you got into R for data science and discovered Tidy Data, this was kind of like the entryway for you into like more population scale statistics, kind of like looking across patients, and that's kind of like that what got your thinking down that track, or say more about that.
Yes. So one thing I didn't understand is just how powerful a few number of skills can be. If you have good Excel hygiene, if you can read a few files into R or Python and like write a handful of functions, you can learn a ton about data. Lots of people can do that. Also, the thing that I bring there is that I live and breathe the data at the source of the data. Like, I am the data generator. Like, you're
the data. You're the data generation process.
I am the data generation process. I've seen the nurses. I know how they scan up immunizations, and I know how that data gets entered into the EMR. And then through more clinical informatics training, like, oh, I know what cache is. I know what clarity is. I know why it's stored there. Like, I get it. But going back about the data creation and understanding how to do things, I can think of different times in my career as a practicing physician where I just felt so frustrated that there were basic questions I could not answer. So, for example, while I was practicing in Hawaii, for complicated reasons, there's a lot of the population has a lot of eczema, so atopic dermatitis. And so a lot of people are familiar with this very common condition where you can think of it as like extreme dry skin. But it's not just dry skin from like, oh, I washed my hands too many times while I was cooking this weekend or something like this. It's like, it's in fact an immune-mediated reaction in your skin that needs immunomodulation to be well treated. And then once you get under the control, maybe just Vaseline is going to take care of it. And so because it was so prevalent and so extreme, it was kind of like out of the range that I was familiar with, having worked in residency. So I actually had to start using some drugs that I had not previously been very experienced with. So I had guidelines from our local pediatric dermatologist, and I was following those guidelines. And then one day I see that a black box warning has been put onto this drug. And I have
What's a black box
A black
warning?
box warning is like where I think it's the FDA, I'm pretty sure it's the FDA, comes out and says this has maybe unacceptable risk.
Like we're considering, even like we're like taking it off the approved list, kind of. It's on like the path.
It's on that spectrum of like
Okay.
it changes the calculus of whether the risk, because there's
Risk
always
reward.
risks.
Yeah.
Yes.
Yeah.
If it's no longer worth the risk. And so I believe the concern was cutaneous lymphoma. And so cutaneous lymphoma is like a weird, like it's uncommon. And so even a few cases of it would make you very worried. And the additional thing is that cutaneous lymphoma is a reasonable complication if you're thinking physiologically, like, oh, wait, I'm suppressing the immune system in the skin, and then suddenly I have a cancer of the immune system in the skin.
Yeah.
So it's like, not only is it scary, it's plausible. So that's very scary. So I call up the pharmacist, like I still have the thing in my hand, calling up the pharmacist, and I say, I need to know every patient that I have prescribed this drug to. She's like, I can't get that data for you.
Wow.
And I was like,
Mind blown.
What?
Yeah.
mind blown. And maybe it was just like that pharmacist couldn't do that, or they didn't have time that day or something.
Right, because you weren't asking like more complicated questions like, hey, have any of my patients actually gotten this cancer, or
Exactly.
how well is the
Yeah.
drug working, or like more it's just like, what is the count of patients?
Yeah.
Right?
Give me their
It's
names.
just and it's like, we
Yeah.
can't do that.
We
We
can't
don't
do
know
that.
how many patients there are. It's like, what?
Do you think it was like an access issue? Like they may not have had access to like write a report in the system
Correct.
that would have
Yeah.
pulled that, and like
And
that
again,
type
this would have been 2016, 2017. So yeah, there's
Yeah.
like difference and what people have in this system or that system, or what this particular person has.
Yeah.
But also the question is, why, as a savvy physician, do I not have that ability? And like lots of has changed. Like, I mean, a lot has changed in this world. But that is just an example of the kind of question of like, that's something I want to be able to do very rapidly. Another thing that I think is an example of like things that physicians really, really want to know is we don't always know how things turn out for our patients. Like,
Yeah.
if I saw these kids in the ED, let's say I saw a cohort of patients over the past 6 months at asthma exacerbations, and I did XYZ for them. Well, and now this last 6 months, I've been doing ABC. Is there any difference? I don't know. It's really hard to look at all that stuff. I think it's getting easier now with some of the reports, but it's not always easy to get that like at the point of care, like asking the questions that you want to do. So love the data. Think about all the time of like how this data gets in there. And it's a bit of a mysterious process. And a lot of people are working with data. But where are they picking up the data? How do they know the data? At what point in its life cycle do they know it? And I like to think of myself as like a complete vertical integration of the data from generation to final reuse.
I think that's a really good example because I think I see a lot of people who are extremely frustrated with things like this. And oftentimes it seems like their reaction is, I blame the EHR. Or my interpretation of this is, I can't get the answer I want, it's because of this technology in some way. And like, as I formerly was an Epic Willow builder working for a health system, and it's definitely there in the data, right? Like
Yeah.
everything is recorded, so like it's certainly possible to pull that list. But to like, there are those barriers that people seem to not really like. There's like, oh, does this person have access to write a report? If you have to send it to a reporting team, is there a 9-month backlog for new reports that team is like working through, and therefore is like not going to like get back to you? There's all of those like non technology barriers, but a lot of times it feels like people look at it and they're like, I blame the EHR because I can't get the answer I want. Is that something that you also see? Like, or not to like jump to the defense of the EHR, which has so
Yeah.
many problems,
Hey,
but
Phil, somebody has to.
Yeah.
yeah, somebody
They,
has to. I'll take the hit, I guess.
So this is my personal journey on that thing. Before I did fellowship, I would often ask myself, and this is not specific to any EHR at all. I would say, why are EHRs so bad? Why do they work so poorly? After I did fellowship, I said, what I say now is, I can't believe they work at all. Given all the constraints, all the players that need to go into it, the critical nature of many things going on, the incredible legislative, statutory quality building, like it's so impressive that anything works at all. So
Yeah.
like I've definitely shifted that perspective. What I will say is that sometimes it's very easy to get anchored in what you see and are experiencing right now that closes you off to what could be. And so I think I'm really hoping that like a lot of these EHR big players now are trying to, like, they're thinking about like what is coming in 5 years, in 15 years or whatever. But I get worried about that anchoring of like what is and what could be, because I think there's just so many, the technology that we're like fundamentally using for some of these EHRs is like based in the 70s, right? It's like, and I'm not blaming, like that's not a bad thing. It's like, it works. It's working. But like, I'm so excited about like what could be. But sequel is always going to be there. From the Phantom Menace episode, I thought to myself, sequel will always be with us forever.
seems like it. I'm curious. I'm curious to pull on that thread more. So, do you have specific, when you think about the future of the EHR from an informatics lens? Are there certain things that you're excited about? Maybe like with like recent developments in AI over the last couple of years. Like, are there specific things that you're like, this is going to be really neat in the next 5, as you look ahead, maybe 5, 10 years or whatever?
Yes. 2 things, though, I think are really important that I like. If your listeners hear nothing else, these are the 2 things I want to tell them. First, the computer is not the patient. They are 2 separate things. There is no way to deconstruct, to flatten, to make a patient legible into an EHR. It's just not possible. There's no digital representation of a patient, of a disease process that will fully capture everything that we need to know. And we shouldn't try to do that. Just trip over ourselves. So big thing there is remembering, like, do what computers do well and don't try to do things that it doesn't do well. Like, things might change over time and like we'll be able to pull in better this or that, but like be realistic about what you're able to represent well and what you're not able to represent well about a patient.
And what just to like get into that a little bit more, what would be an example of like trying to represent too much information? Because one kind of like analogy that is kind of common, that I've heard a lot over the years, and I think I may have even used over the years, is like, well, compare like healthcare to the airline industry, right? What the airline industry does is there are a bajillion sensors on an airplane that are sucking in like gigabytes, terabytes of data on an airplane every second, every minute, every day. And it's just instrumented like up and down to the extreme, to the point where it's like, we kind of know everything, right? When something's about to bad happen, and like, whenever there's a plane crash, like we ultimately figure out, oh, it was this thing and this, and right. And so I hear a lot of people kind of compare that to healthcare and say, well, we're just not collecting enough information frequently enough. And if we had more, we could kind of like do the same thing.
Yeah, the challenge there is, I would say, whenever you're asking, like, can a computer do it better or can we have a tech do it better? Keep in mind that health tech and medicine are not the same thing. They're related, they work together, but they're not the same thing. Could a human physician focused on this problem for this patient take care of that problem? And if the answer is no, then you got to think really deeply about, like, is this a health tech problem? For example, I could spend a whole week with a patient saying, please stop smoking. I'll sit next to you and slap your hand every time you reach for a cigarette, and I still might not be able to stop them from smoking. And so, like, them getting an alert on their phone to say, like, did you think about how you're not going to smoke today, might not be a great use of the resource. So, like, just matching what you're trying to do and thinking about, like, what's the non-tech solution to this, and does that exist? If that doesn't exist, think really hard about why it doesn't exist. A good example here is actually along the lines of smoking. How anybody who has worked with smoking data in EHRs will probably need to like go outside and scream for a little bit before they come back inside and talk to you about it.
Absolutely.
I assume it's complete garbage, like unusable from like an observational standpoint.
It's not, but it's hard, right?
I lie all the time about that. I'm not a regular smoker, but like, in college and like past lives and stuff. And the question is like, have you ever smoked? I'm like, no, because I don't want to like sit in.
I don't want to talk about it. Like, have you ever smoked?
Yeah.
Did you, and do they count like, oh, you had 100 cigarettes in your life? And you're like, I don't know. There wasn't like a number on them.
Like a clicker that you've been keeping going every single time you smoke a cigarette.
But here's another good example of like the sensor example you were talking about with airlines. I can smell so many things in a patient room, and there's like very difficult way to capture that in a medical record. Like, I can describe a smell, like musty smell or something like this. In pediatrics, this is, at one time in time, I really wanted to do genetics. I did not go and do a genetics fellowship, but like, there's certain genetic conditions I can smell. I can walk into the room and I'm like, yes.
No way.
I know what this is.
Oh, wow.
Liver failure. I one time just like offhandedly mentioned to a friend of mine who's an internal medicine doctor. And I was like, oh, the liver smell. And she's like, what are you talking about? I was like, when somebody's liver is smelling and they're failing and you can have the smell. I grew up going to church behind a gentleman, he's actually sat behind me, who had liver failure. So for like 7 years of my life, I like smelt liver failure every Sunday. And then so when I went to the hospital as like a third year medical student, I was like, oh, that's liver failure. Like, I know what that smell is. You need to look into Parkinson's, the smell of Parkinson's. Go look this up on YouTube. Please, listeners, go do this. there's just things, because they are not legible to a medical record, whether that's a written record, whether it's a computerized record, it is difficult to get the signal there. Because it's very difficult to describe a smell. I can't describe the smell to you, like, really, about what these sorts of things are. Or a particular type of gait that is indicative of alcohol abuse, chronic long-term alcohol abuse that destroys part of the brain that is involved in the coordination of walking. Like this kind of like, you'll see the neurologists are very eloquent and they can have lots of like fancy words for these things. But like, it's like 1 second of gait and I can watch that. 1 second of somebody who has Parkinson's or early Parkinson's trying to stand up, and it's like, yes. My husband says it's not very fun to be with me in public because, like, I notice a lot of things that I wish I did not notice.
Oh
right?
my gosh.
Yeah. So just stepping back there and looking at the general principle, there is so much in the world that we can see about patients that we can't capture well. Simultaneously, there's so much out there that we are not capturing because we don't know. When I was in second year of medical school, we take a pathology rotation at University of Iowa where it's like a year long. I think it's actually one of the I would say it's great. I hope they haven't changed it. And my instructor would say, the eye only sees what the mind knows. And so when you look at if you guys have seen like these little path slides, they just look like, if you're uninitiated, you're like, I don't know, it's kind of pinky and purple. But like once you learn the language of like description and like being able to think, you can pick out things that it's just unbelievable what you can see if you understand. And so I think that is analogous. There's so many things that we could be seeing right now that because we don't have a framework for it, we don't have words for it, we're not capturing it. So I always think to myself, whenever I hear about like some horrible medical practice we were doing like 50 years ago, I don't think to myself, oh, tisk, I can't believe they were doing that. What I'm always worried about is like, what am I doing right
Today
now that my great-grandchildren will be like, Stone Age, absolute Stone Age.
Yeah,
but like that's
absolutely.
hopeful, right? Like I hope my great-grandchildren are not in the Stone Age of medical practice.
Just to drill on that point about the airplane and the sensors and stuff, like, and to your point about having so many things that you can observe if you understand them, it does seem, I was just thinking back to time that I spent curating observation data and flow sheets, and it
Oh
was
man,
actually
the
kind
flow
of
sheets.
it was shocking to me how much of the bulk of those little text snippets was describing like someone's pallor or like what their skin like. Do you have a waxy skin or like
Cool
all
extremities, clammy
exactly
extremities.
like what like just describe. And so I was describing this to a bunch of people somewhat recently who had no context for this, and they were like, it was very hard for me to describe, like, yeah, so you can look at people and observe things about them and then write it down about like their pallor, their temperature, what their skin looks like, all of these things, maybe sometimes even smell. Um, so do you think that like we could be doing, we're sort of doing it. We're putting a lot of stuff in those little text snippets just as like natural language. Would you advocate like, having like a quadcopter with like a camera on it in the patient room, like trained to like make observations and then like encode everything like that as like a SNOMED code? Like I'm sure there's a SNOMED for everything that you just said somewhere, among the like 10 million SNOMED codes or however many there are. Like, should we
Yeah.
try to do that? Or how do you feel about that kind of attempt to quantify the sort of
every
subjective sort of
variable. Yeah.
just should we try to get
I,
everything?
Do it for 10 patients and tell me if the outcome's any better than not doing it.
yeah. This was kind of you're going to you're going to make 2 points, and then I interrupted you and we went down this super long tangent. But your first point was basically don't try to do that.
Don't try to do what? Sorry, I lost you a little bit.
Don't try to like capture every piece of information. It might not actually matter.
It might not matter. Yes. I think I'm having a hard time remembering all my wonderful thoughts that I was going to share with you guys. But one of the things that I think it's really important to think about is like that you will know them by their fruits, right? If you are doing a process or if you're like doing some sort of analysis, like what's the outcome? What's changing? And so I think, Phil, you were asking about, the future, what does the EHR look like? So there's a couple things that I see coming that are what needs a physician and what does not need a physician. So I really like to think about this over-the-counter concept of like what kind of medicine can we just like lock up as we understand 99% of the variability here, and it just no longer requires a physician to do this. I think obesity is actually one of those things. So I think there's a lot of commodity medicine out there, especially in chronic disease. Like the GLP-1s, are you guys familiar with the GLP-1s? So for the listeners who might not know, like GLP-1s are this class of drugs, and there's like other ones that are like quasi GLP-1 and mixtures, and the new one, the junior generations are going to come on. But they have an incredible appetite suppressant or appetite modulation. And it's not only just appetite for food, it's appetite for alcohol, for tobacco. As long as there's not like a really terrible outcome from side effects of these drugs, which it could be, like tomorrow we could hear about the cutaneous lymphoma black box warning, right? Like,
yeah, stay tuned.
Stay tuned. But the flip side of that is obesity is really bad. It's so bad. Like, this is actually funny, like in the sense of like, it's so bad that I wish people would stop publishing papers about how bad obesity is. It's like, we don't need
more research there.
There's
like
no more research. We
Yeah.
know it's bad. Like, I don't need to know the particular like inflammatory like markers that get elevated in like post knee replacement patients who are obese at this level or that level. It's bad. We shouldn't be obese. And so there's a lot of this kind of care that I think it can just be boxed up, and like we shouldn't even be thinking of it as like normal, like of complicated medicine. It's like the easy medicine. It's like, okay, you have a little fungal infection on your skin. You can go to Walmart and you can get an antifungal and take care of it. You don't need to go to the doctor. Like, there's a lot of care that does not need to be with a physician. I think that's a very complicated process, legislatively, politically, professionally, like all those things. But my idea here is that we have to focus our energies on where that professional insight, where that data insight makes a meaningful difference. And like sometimes it doesn't. Sometimes it's just like so straightforward of like fungal infection on your skin, treat it with an antifungal. There's not a lot of thinking. We don't need any more data to understand that this is the right decision. And so focusing on the cases where we do need more data to figure out what's going on. And so I think, there's just like a lot of opportunity in things that we are still very familiar with. For example, I think sepsis gets missed way more than it should get missed in the hospital, in the ED. And this is like something people care a lot about.
Yeah.
And we're still not figuring it out quite right. So it's not that everything's getting simpler, but there are some things that might be going the way of like, this is just a commodity form of medicine at this point in time. Like, you get a diagnosis, this is the treatment. Most people don't need any more like follow-up other than that, or a standard follow-up.
I'd love to maybe move toward what what led you on this trajectory from Iowa to California to Hawaii to New York through medicine, interested through like got more interested in the informatics side of things. And in the last couple of years, you've transitioned to working in health tech, to actually working for technology companies. I'd love to know, like personally, how that like transition like kind of emerged and how that came about, and how that like where the connection to your interests kind of evolved to lead to that point.
Yeah, I think one of the things that a lot of people who go through the levels of training that I have gone to, I have so many degrees. It's like embarrassing. Like I'm embarrassed to say how many years of my life I have spent in like post-secondary education. But a lot of the people like in my position are in academia. They're publishing papers. I have never been a paper publisher. Like it's just like never been interested. Though that's not for the lack of like I want to tell people about the things in the data, but I like to lurk a little bit more in the background of like here's the data that I think you will love, and like you go do what you want to do with it. And I think the ability in industry to just like move very quickly, use the newest tools. Like I actually learned about DBT from Tuba, Aaron. I'd never seen that before. And like it doesn't matter what the exact technology is, but thinking about how you can trace your entire lineage of your data, every little step of like, changing it, modifying it, reusing it. Like I used it for this purpose and now I'm going to use it for this purpose and I can go back to this stage and, it's reusable for all these sorts of things. It's just like, it's a completely different way of thinking about how you handle data. So many people in academia, they're just focused on their problem, their data, and they don't care about like if this data can get reused again for another project. They're getting this grant, they're getting these papers out, done. That data might get buried somewhere on some hard drive somewhere and never get used again.
Almost
Like
certainly.
that's not my thing. My thing is like, how can we turn the data pipelines on in the least, I'm going to use this way, I am trying this word out, the least opinionated way of processing the data. And what I mean by that is, if you do not know about why your data is being collected, you should not be using that data. Like, proceed with caution, buyer beware kind of things. And I can go, the smoking example is a great example of that kind of how you can really get fooled by what's in the data. And so this was the big calling for me, is that I feel like I'm a mother bear of data, in that I love data. I want it to like shine. I like want it to be beautiful and everybody to use it. But I'm also incredibly knowledgeable and aware of where the shortcomings of the data are. And if you do not, like, you need, every time you're picking a new data source, you need to think very carefully about like, what is this data good for? And what are the problems with this data? You show me a data set and I will show you things about that healthcare data that will make you cry. And if you need to know like how your data is wrong, because if it's wrong in the way that matters for your analysis, like a really great example of like wrongness in healthcare data is like, Phil, you know this from flow sheet data. Graph your systolic blood pressures that you are getting out of your data. Can you guys guess what you're going to see?
I mean, you definitely see some like I don't know, 18 standard deviation like outliers where somebody has like put in a zero when they didn't mean to and stuff like that
Sure,
for sure.
sure. You have all sorts of
Yeah.
like data quality things. You're
Negative
going to,
numbers.
at every clinically significant guideline cutoff, you're going to see a shift of the data. So at 140 millimeters of mercury for systolic blood pressure, you're going to see a whole bunch of 138s and you're going to see a whole bunch of 142s, because the nurses are sitting there and they're like, if I say it's 141, that's going to trigger a whole lot of problems of this. So there's
Clinical guidelines impacting the data
clinical
generation process.
data entry. And so now look at data that's coming in from automated blood pressure cuffs. There's like no human in the loop. The physician, or maybe the nurse, just accepts it. That's not like manually entering it in. So you're going to see all sorts of crazy things like this in the data. And if you're not like aware of like,
Yeah.
that data entry is actually a human process oftentimes and has human like foibles baked into it.
There's some pretty great papers about like changes in coding practices that just happen to coincide with like changes in like HCCs and stuff.
Definitely,
Like,
definitely.
oh,
This
like 2016 versus 2017, completely different incidences of like
this
certain
this is a
things.
perfect example that I was talking about of like the patient is not the computer. And so ICD codes for people that aren't aware, these ways of trying to like classify disease, but it's just one way of like classifying it. Like over time, people will decide like, oh, actually, you need these three things to make the definition of acute renal failure or something, like acute kidney injury. Oh, we're going to change the name over Mara's career several times so you can date her. But it's not real, like, right? Like, I'm not taking a chunk of tissue and getting a immune marker that's saying, yep, this is like ICD XYZ dot zero. These are like generic ideas of like what the disease is, influenced profoundly by the billing of that. If I code this person with diabetes complications, that's a completely different thing than if it's diabetes without complications. And this is another thing that's like kind of like always a head scratcher for me, is that when I hear people talk about like their AI product or their thing or the problem they're trying to solve, because like they're chasing high reimbursement situations. And if you like, it's a constant cat and mouse game. It changes. This is a higher reimbursement. More people are going to go after that in reimbursement. Then they're going to change it so that it's not as well reimbursed and something else. So this is like, I mean, Erin, I think you probably know this way more because I don't actually deal with claims as much as like you guys do, but I see it from the diagnostic classifications of things that are incredibly sensitive to secular trends that are not related to the actual biology of what's changing for patients.
So where do you I think that this conversation is always really interesting, and I've encountered people who are really just focused on the data, who are very naive about those types of things, like who honestly just don't know, like what an IC, in some cases, like what a CPT code actually is. It's all just features, you're like throwing some features
Exactly.
in the model. Um, do they have modifiers? Do they not have modifiers? We don't know. We don't know what that is. We're just putting the thing from the column in the model. Then I've actually had maybe more from the academic informatics side. Like I did a master's degree that included some informatics stuff. And I've had people say, like, if you are trying to study something and your data set was not collected for the purpose of studying that thing, you should not use it. Like it's useless. So I mean, obviously the truth is probably
It's a
somewhere between those
spectrum.
two
Yeah,
poles.
Yeah.
yeah. Like
But
I'm
like, where do
swooning
you
over
kind
here.
of come down? Like, where do you kind of come down
Yeah.
on the like the spectrum there?
I think it is all about how to put this. It is all about going back to the strengths and the weaknesses. And this is, I was like lambasting a little bit like people publishing about obesity. It's like, we don't need any more about that. Like we know. And sometimes people have a question that's a really good question, but do they have the data they need? Or is this just the data you have? And being super honest about that, of like, yeah, this is not the perfect data, but it's what I got.
But
And
what
this
can we still do with it? basically.
Yeah.
Not letting perfect be the enemy of good.
Do not let the perfect be the enemy of good. However, one thing that's always like made me very sad is how much signal you can actually get from a very small amount of data. Like, you could do things to totally put to bed some medical controversies with 100 patients. Like that. I know that sounds silly, but it's true. Like for example, I'll keep my opinions to myself, but I'll just say, as a pediatrician, there's this big issue with head flattening. And it's related to that we put babies on their back to sleep. And it's like, what do we do with all these things? There's a lot of questions and a lot of tensions in there. And I'm pretty sure you could do a study with 100 to 200 patients, and you could put you would know. You would know. And it's so tempting though to like, I have the data here, I can just use it. So yes, it's being very, like, you need to be very knowledgeable of like, where's the data coming from? Why was it collected? And like, you need to like play, devil's advocate with your data of like how, and if you can't do this, find somebody who doesn't care about your project. Call me up. I'll tell you.
Red team it. No. You need to play detective and interrogate it.
Yes. So I actually, here's my, I'll throw this thought out for you guys. You guys know the show Car Talk?
Yeah.
Did you guys grow up with this? I would love to do a data talk where people like call in and they tell me like, my data is outputting this problem. And I'd be like, wait, if you do.
Oh, we should do that. We should do that.
Yeah. Like, you really just have to, like, you have to interrogate, you have to be the mean guy. Think about how your data could be failing you, and think about what the alternative is. Like, what other kind of data could I get that might answer this? The follow-up thing to that is, do not confuse a proxy outcome with the real outcome. This I see over and over and over again. Like, it does not matter if you're trying to like improve asthma outcomes for your kids in inner city Boston, and your outcome of success is whether or not they filled their like controller medication or their rescue inhaler, like, that is an outcome. It's not the outcome of these kids had more days in school, these kids slept better, these kids had fewer visits to the emergency room, or these are just like the very simple thing of like, these kids' parents said they were better this year than last year. Like, this is like a fundamental problem I see over and over and over again.
Well, I hate to be the one to stop the party here, but I'm late for an all-team meeting. Mara, it was so great having you on. I feel like we could have gone for another hour. We're gonna have to do a part two
I can talk about data all week, all year. Just let me know. It was such a pleasure to be on. I'm really excited to hear who your next guests are. I listened to your other two. So lovely,
Awesome.
lovely.
Thank
Thanks.
you. It's great to chat with you. Thanks.
Bye.
Thanks for listening to this week's episode of the High Dimensional Podcast. If you liked it, we'd love it if you could leave a review on Apple Podcasts or wherever you listen to podcasts. Soon we'll be back with more exciting episodes at the intersection of healthcare, data, and AI. We hope to see you soon.